Well, aloha everyone, and welcome to the review for Exam 3 for Anatomy 1. It's going to cover units 7, 8, and 9, namely the axial skeleton, the appendicular skeleton, and the joints and articulations. I apologize. All right, so for this exam, you're going to need to know specific structures. So I know I gave you a lot of different structures and all of the different diagrams, but the ones that are listed here are the ones that you're going to need to know. That includes different types of surface markings. So know different types of depressions and openings, the names of all of these nomenclature, including a fissure, foramen, fossa, meatus, etc. Then also anything that's going to form a joint, something like a condyle, which is like a protuberance, is going to be round, a facet, a head, etc. And then other types of connective tissue regions that are going to be processes that protrude off of the bone to allow attachment of the connective tissue. Crest would be something like a ridge, for example, a condyle or an epicondyle. An epicondyle is going to sit on top of a condyle. The sphenius process is going to be a slender projection. This is found on the spinal vertebrae. Trochanter, specific to the femur. So go through these and recognize not just what kind of nomenclature you're dealing with, but where we might find something like a tuberosity, right? The sacral tuberosity is a pretty classic one. If we're looking at the cranial bones, I have several different images that I took out of the PowerPoint that you guys need to familiarize yourself with. And basically anything that's going to be in all caps is going to be a facial bone or a skull bone, cranial bone that you're going to need to know. Okay, so the cranial bones obviously back here, skull bones towards the front. And these images are going to depict the same bones from many different directions. So the bones you'll need to know are going to include the frontal bone. Again, that's going to be depicted in many different locations. It's depicted in blue, so it's here or it's there. So depending on which image you're looking at, you're going to be able to see them from different angles. So we have the frontal bone, the parietal bones, the temporal bones, the occipital bone that's here in the back. This one is going to be the parietal bone. Here's the temporal bone, sphenoid bone, etc. The ethmoid bone as well. The ethmoid bone is going to be the specialty region of the cribriform plate. This is going to be where we're going to allow olfactory nerves to go in and allow us for the sense of smell. This allows basically the exchange from the molecules that are touching the olfactory epithelium inside your nasal cavity to be able to communicate through the olfactory nerve to your brain. Again, that's going to happen through the cribriform plate. That's found on the ethmoid bone. That just might be a test question. All right, moving forward. These are all the different sutures. You're going to need to know all the different sutures. The sagittal suture is going to go between the two parietal bones, for example. We also have the lamboid suture that's going to separate the parietal bone and the occipital bone. Here we're going to have the temporal bone on either side. What else are we looking at here? We have a lot of different things that are also depicted in these images. So not just the things that are here in all caps, those are the names of the bones, but also many of the different processes. So the mastoid process here is going to stick off of the temporal bone. It's going to be the area. It's going to be involved in mastication, so it's going to allow for the muscles to attach down here to the jawbone to allow us to be able to undergo the process of mastication or chewing. Here we have another little protrusion off of the temporal bone called the styloid process. Again, that's going to connect down to the mandible to allow us to chew. Let's see, other notes of interest: foramen magnum, the very largest hole in the body, for example, that's found in the skull. So don't just know the names of the actual bones, but know the defining features, like the sutures, for example, where you might find particular processes, etc. All right, so we're going to move down a little bit into the facial bones. The facial bones are going to be all of the bones that you can see, obviously looking from the anterior view, so towards the face of the individual. It's going to include some of the bones that we already talked about, like the frontal bone is actually going to both be a facial bone and a skull bone. But moving down from there, here we've got this here is the nasal bone. Behind it, we're going to have the ethmoid bone. Beneath that, we have the vomer. There's going to be the maxilla. It's going to be the upper jaw. Mandible, that's the lower jaw. We have here the zygomatic bones, 1 and 2. We also are going to have the sphenoid bones. And one of the questions that comes up is which of these is a paired bone or is not a paired bone. So as you go through, pay attention to whether or not it's going to be symmetrically paired, like we have 2 of them, or it's going to fall right in the midline and then we're only going to have 1 of them. All right, so this is the list of the vocab terms that are all fair game. So the nasal bone, lacrimal bone, palatine bone, which is going to be, you can't see it, but it's at the hard palate, so it's going to be at the top of the mouth. Inferior nasal concha, vomer, maxilla, zygomatic. So make sure that you know each of these and where they are. Again, this is just a really good region to throw down a bunch of post-it notes and write over top of them until you actually know these bones in and out. It's another good thing that I mentioned, another good idea that I mentioned previously in class is to go ahead and get yourself a coloring book. And you can go ahead and use your different colored pencils to color in that coloring book so you get really familiar with the different bones and how they articulate from different points of view, right? Okay, so I'm going to move on here. This is another point of view. This is an inferior view. So now we're looking upward. We're going to be looking up through that foramen magnum. This is going to allow us to see that the palatine bone, which previously we weren't able to see here. This is the hard palate. Behind that, we're going to have the soft palate. And then, of course, this is going to be part of the maxilla. So this part of the very front of your mouth is going to be part of the upper jaw or the maxilla. All right. Let's see. This is going to be yet another view, all the same bones again. So anything that's going to be in caps, I want you to know. So parietal, occipital, temporal, sphenoid, ethmoid. We have the cribiform plate right there in the ethmoid bone, frontal. So just go through there until you can do it the way I just did it. Rattle it off by knowing which color is what and where they're located relative to one another. Again, you're also going to need to know all of the sutures. So these are going to be sutural bones that are going to come together between the occipital and the parietal. We also have a lot of sutures where the bones themselves are just going to kind of fuse together. Again, we have the sagittal suture, the coronal suture. Here's the lambdoid suture. It's going to connect the parietal to the occipital. So yeah, just know all those different sutures. Additionally, we have sinus cavities, so know the different sinus cavities. Remember, we talked about the upper cavities being the frontal sinus and the frontal bone, and the bottom being the maxillary sinus found in the maxilla. And then in the middle, if we had a sinus infection in the middle, we might ask the individual if they feel it towards the front of the skull or towards the back, towards the brain. And that would be the difference between the ethmoid sinus and the sphenoid sinus. Other things of interest in the fontanelles are going to be the areas between the cranial bones that are going to turn into sutures. Here's the posterior fontanelle, for example, the posterior lateral fontanelle, etc. So other things that are fair game are going to be the different fontanelles that are the spaces that are going to eventually become sutures here in a young child or an infant. Okay, again, you need to know all four of those. Hyoid bone, free-floating bone in the front and the neck, has the greater horn, lesser horn, and a body. Again, from the other side, greater horn, lesser horn, and body. So again, not only do you need to know the names of the bones, but you need to know the features of the bones, so that you can kind of have an idea of not only what those features are, but how those features are going to articulate with the surrounding, in this case, tissue, which is unique. Remember, most bones are going to articulate with other bones, but the hyoid bone and the auditory ossicles are going to be what we consider to be free-floating bones, in that they're only going to be interacting with connective tissue and not with bone itself. All right, so next we're going to talk about the vertebral column. We're going to start moving down the vertebral column, starting with the cervical curve. The cervical curve is going to connect, it's going to be just inferior to the skull. We have 7 sort of cervical vertebrae. Then we have the thoracic curve here, which is going to form the 12 thoracic vertebrae. Then the lumbar curve, the sacral curve, and the coccyx. So you'll need to know the difference between these different regions and how to identify from the different bones which area you might be interacting with. For example, if you have facets, to be able to interact with the rib cage, right? So the costal bones, then you're dealing with the thoracic curve, because these are going to be the ones that interact with the rib cage. These obviously are not going to have articulation regions for the ribs. Same with the lumbar curve. The lumbar curve is much larger than the cervical curve. So again, you might be looking at something like size and shape and curvature in order to determine the apparent position of the vertebrae that you're holding. Cervical vertebrae are going to start with the first two, C1 and C2. That's atlas and axis. These guys have specialty regions where we're going to have these foramen, these transverse foramen, where we're going to allow for the passage of some of our cranial nerves, as they're going to, the ones that are going to go down through the neck and innervate the body. The thoracic is going to be when we have articulation for our ribs, so the costal facets, or the areas of the bone that are going to articulate with the rib cage. So anytime we see these regions for the demifacet for the head of the rib, we know we're dealing automatically here with the thoracic. Moving on, we have the lumbar. Right, the lumbar here is at the bottom. The lumbar is going to be much stronger. It's going to have much bigger body, for example. And also, these are going to be features that you're going to see of several of the vertebrae. We're going to see a sphenius process, the articular process. Each of the articular processes are going to have superior and inferior articulating process that are going to articulate with the upper and lower regions. So again, each of the vertebrae are going to have superior and inferior articulating process. This is the transverse process, which is going to be connecting the body out to these articulating processes. All right, moving down, we're going to enter into the sacrum. The sacrum starts off as 5 individual bones as a child and is going to fuse into the sacral vertebrae, or just a single vertebrae, as an adult. Same with the coccyx, starts off as 4 and becomes 1. We are going to have a specialty region here. This is the median sacral crest. We also have the sacral tuberosity on the outside and several sacral foramen. So this is a very easy bone to identify. Very distinct. These are different abdominal curves of the vertebral column. So kyphosis, if your head kind of slouches forward a little bit and your shoulders roll forward. Scoliosis is if your shoulders kind of roll up or down one direction and your hips are going to follow the same thing. So you end up with that kind of an S shape. Again, hips down, hips up, shoulder down. And this one, shoulder up, hips down. So we're going to end up with a difference, but for sure, where we have lines going this way as well as that way instead of our lines being level. All right, so lordosis is when the lower back has an abnormal curvature, and any one of these can lead to severe pain in the individual, as well as, in this case, loss of height, probably loss of height in all of them if it can be severe. All right, so let's move on here to the intervertebral discs. Intervertebral discs are going to go in between, here we go, in between the vertebrae. Here they have 2 different regions, the annulus fibrous, which is an outer region that's very strong, and a nucleus pulpus, which is an inner region that's a little bit more flexible. And if we have a slipped disc, or we can have a popped disc, where we have the nucleus pulpus flipped outside of the annulus fibrosus, and that can be very painful because, as we see when we overlay the spinal nerves, you'll see the spinal nerves are actually going to be running right on through that same region right next to those the vertebral discs. Okay, so this is the vertebral structure. As I mentioned, we're going to have the vertebral body. Then this one is going to be these demifacets are for the ribs. This is a thoracic one, so you can tell because we have extra facets that we don't have on all of them. These superior and inferior demifacets are going to be for the articulation with the costal bones or the rib bones. Here we have a superior articulating facet and the interior articulating facet. They're going to articulate up and down with the vertebrae above them. Here's going to be, I apologize, this is the rib tubercle. I had it oriented backwards in my head. This is the rib tubercle, and these are going to be demifacets that are going to allow for articulation with the the vertebrae above and below them. So I apologize for the misspeak here. Really, I was just pointing to the wrong thing. But here's going to be the articular part of the tubercle of the rib. And again, that's how we're going to identify that it's a thoracic vertebrae. This is spinous process. This is going to orient us towards the back of the individual. So you can tell this is the posterior and the anterior views. All right, so now if we're going to overlay several of these vertebrae together, and we're going to add the spinal cord going through, and we've added the intervertebral discs. So we can see here we have the facets for the heads of the ribs here. That's where the ribs are going to articulate. And then here's the superior articulating process going to articulate with the superior vertebrae, and here's the inferior articulating process of this vertebrae, which will be articulated with the superior articulating process of the vertebrae just inferior to it. All right, so yeah, let's move on a little bit to the thoracic cage. This is how we're going to have our costals or our rib cage attached to both the vertebrae in the back and to the front to a region called the sternum. So let's look at the sternum. The sternum has several regions. It's the breastbone, 3 regions, the manubrium at the top, the body, and the xiphoid process. The body is where you're going to put the bottom of your wrist, but you're going to be doing CPR on an individual. You'll be putting the base of your wrist right here on the body of the sternum to do compressions. In that little butterfly region here, that's called the xiphoid process. And we're going to be connected by costal cartilage. We have several different sets of ribs. We have true ribs, which are going to connect directly, like number 4. And then false ribs, which will connect indirectly, like numbers 8 and 9. That starts here, I believe, at 7. All of these are going to be considered false ribs, or maybe 8, 9, and 10 are considered false ribs. And then 11 and 12 are actually not even going to be connected at all. They have a little bit of cartilage that sticks over, but they're not even connected to the sternum in any way. So those are definitely going to be considered false ribs. All right, so a rib is going to have several different regions of the bone that are recognizable. First, we're going to have the head and the neck region. The neck region is going to be just above a tubercle region. The tubercle region is going to be able to have an articulating facet that's going to interact with the spinal column. And then as we go around, we have the costal angle and the costal groove. And then this is the facet for the costal cartilage, which is where we're going to be connecting in the front, again, towards the sternum. All right, so what does it look like when we take these ribs and we actually interact with the vertebrae? So these are articulating rib and vertebrae interactions. Here's a transverse process of the vertebrae. The facet for the tubercle of the rib is going to come in and connect with that transverse process. Again, here's the costal angle and the costal groove. We're going to have an intercostal space. We're going to have muscles and all sorts of things are going to run through here. So this is just going to be kind of a support network, obviously. Okay, so again, we have two different sets of ribs. The true ribs, which are called the vertebrosternal ribs, meaning that they actually connect from the vertebral column to the sternum in the front. And then we have the vertebral condyle ribs, which are going to connect just to cartilage of rib 7. And then we have those bottom ribs, which are called the floating ribs. And these are not attached to the sternum at all. Both of these are considered false ribs. These guys are considered true ribs. Okay, so I kind of already went over that rib structure, and that's going to take us into Unit 8. Unit 8, we're going to start with the appendicular skeleton. So we're going to be talking about the pectoral girdle and the hip girdle, etc. So here's what the pectoral or the shoulder girdle looks like. It's going to be comprised of several articulating bones, including the clavicle. And here's going to be the humerus, and that is the scapula. Okay, the clavicle is obviously the collarbone. The collarbone has a couple different regions. The acromial end is going to interact with the acromion of the scapula. This is the acromioclavicular joints. And the other end of the clavicle is going to interact with the sternum. So articulates here in the front with the sternum. Okay, so that's going to be here. We're connecting on the sternal end. The scapula is the shoulder blade. The shoulder blade has several different points of interest, including the acromion, the coracoid process, and the glenoid cavity. The glenoid cavity is where it's going to articulate directly with the humerus. Again, that same thing from different angles. Here's the acromion, here's the coracoid process, and this is the spine that connects the acromion to the glenoid cavity region. This here is the lateral border, which is going to be the entire back region, basically, but again, you're looking at it from a different angle. This is the superior angle, the scapular notch. Again, here's the acromion, and the coracoid process is sticking out over here. Again, this is going to interact directly both with the clavicle and with the humerus. Okay, so the upper extremity is going to be including the humerus, obviously at the arms. It's going to include the humerus, the radius, and the ulna. The humerus is going to articulate the glenoid cavity of the scapula. We've already talked about that. And some of the things we might want to talk about in terms of bone surface markings are going to be the greater tubercle, the lesser tubercle, and this is a sulcus here where we're going to have some musculature running through. So tendons and muscles are going to run right on down here, the bicep specifically. All right, at the bottom, we're going to have this lateral and medial epicondyles. These condyles are going to be able to then end in the capitulum and trochlea region. The capitulum is going to interact with the head of the radius. The trochlea is going to interact with the coronoid process of the ulna. Okay, so I've touched on that. We'll talk about the joint when we get up to joints and articulations. Right now I'm just talking about the bones and the bone surface markings. So again, the olecranon is going to be the region that is going to be the back of the elbow, not the fossa. The fossa is where going to be where we have the kind of the indentation that comes down on the back of the humerus, and the olecranon is here. The olecranon and the olecranon fossa obviously are going to interact. Again, that's going to form the very back of the elbow. If we follow the olecranon down, we're going to get down, obviously this is the ulna that's going to reach down to the wrist bone. And here on this side we have the head of the radius that's interacting on the other side here with the capitulum. That's going to come down to the styloid process of the radius and interact with the carpals at the wrist. We have an interosseous membrane that holds the radius and the ulna together. And then we're going to move down, or let's talk a little bit more about the ulna. So the ulna has the olecranon, which is the prominence that it's going to form the elbow, and it has a trochlear notch. It's going to interact here with the trochlea, right? It also has a little region called the coronoid process and the radial notch where the radius is going to interact. And we have a little tuberosity region. It's going to be a little series of bumps or bumpy area. Okay, again, looking at the elbow from a different direction. So here's the ulna. We have the olecranon of the elbow. It has gonna have the trochlea of the humerus interacting with the olecranon and the coracoid process of the ulna. And then we have the capitulum interacting with the head of the radius. Here's the radial tuberosity, the interosseous membrane that connects these two. And then again, remember at the end of the humerus, we have the medial epicondyle where the trochlea is going to come off of, and the lateral epicondyle where the capitulum comes off of. All right, so let's go down and look at the wrist interaction with the radius and the ulna. So we're going to take the radius now and look at where it interacts, and it's going to interact with the scaphoid and the region of this is the styloid process, which is going to be actually kind of sticking out. You can see it on your wrist on the outside part, so it's going to be on the lateral region of your wrist protruding. Here are the articulation for the lunate. Both of these, lunate and scaphoid, are going to be wrist bones. And then here of the ulna, if we bring that down, we're going to have the ulnar notch, which is going to interact here with the the ulnar notch is on the radius that interacts with the ulnar, and this is the head of the ulna that interacts with the ulnar notch of the radius. This here is another styloid process, again, of the ulna. So this is going to be the one that you're actually able to, so both of them you'll be able to feel as your wrist bone. This one is going to protrude a little bit more, that styloid process here. Okay, so again, that's everything that you need to know for the articulations of the ulna and the radius of both the elbow, and now we're going to be talking down here at the wrist. Again, let's talk about the carpal bones. Carpal bones, there's a set of 8, so 2 sets of 4. It's going to include the scaphoid, the lunate, the pisiform, the triquetrum, the hamate, the trapezium, the capitate, and the trapezoid. All right, so know them in order. You won't have to label them in order for this exam. You'll just have to know which is which. But for the lab exam, there will be this pretty much this exact image, and it will be delabeled and de-identified, and you'll have to tell me which of those bones is what. Again, from the drop-down menu. Following it from there, we're going to have the metacarpals. The metacarpals are labeled 1 through 5, or I through V, if we're going Roman numerals, and that's going to be the thumb is 1 and the pinky is 5. Moving down from there, we're going to have the phalanges. The phalanges are going to be sets of 3 in most of our fingers, but in the thumb only 2. So for the thumb, we're only going to have the proximal and the distal. For the rest of them, we're going to have proximal, middle, and distal parts of the bones of the phalanges. Okay, let's move on to the pelvic girdle, or the hip girdle here. The hip girdle is comprised of 3 major bones, the ilium, the ischium, and the pubis. They all come together to be able to form a nice strong hip socket known as the acetibulum. So this is where the head of the femur is going to interact. Everything that is going to be above the acetibulum is going to be called the false pelvis. Everything beneath it is the true pelvis. Basically, the question is it weight bearing? Other notes of interest here for the bone surface markings, these are going to be the gluteal lines. This is where the gluteal muscles are going to be running alongside this bone. We also have the sciatic notch. That's going to be where the sciatic nerve is going to run through. Acetibular notch is going to be this region here. We're going to feed in nerves and blood supply, etc., to the acetibulum of the hip. This is the obturator foramen. It's going to have a lot of membrane through here, but we're also going to have a little hole that allows things like nerves and blood supply to go through. Obturator foramen is going to be involved in the process of obturation, which is going to allow us to be able to move about. So all sorts of stuff is going to run through that foramen. Okay, so the coxal or the hip bones include the ilium, the pubis, and the ischium. They come together to make the acetibulum. The acetibulum is comprised of all 3, as you know, so it's going to give it its strength. We also are going to have the pelvic brim. Pelvic brim is going to have the sacral tuberosity as a landmark here. In the front, we're going to have the pubic symphysis. It's similar to the cartilage that we find in our intervertebral discs. It's actually going to be considered a fibrous joint. Here's the pubic crest, pectineal line, arcuate line, etc. Again, when we talked about the true and the false pelvis is anything above that pelvic brim or the pelvic axis. Anything where if you were to have a break, you would still be able to put weight on your lower limbs. So basically a non-weight bearing break. Anything below that would end up with, you'd have the disability in the disability to walk, at least while the bones were healing. And so that would be considered the true pelvis. And this pubic symphysis or pelvic axis here between the plane of the pelvic outlet and the plane of the pelvic brim is going to be different for men and women. Okay, again, false pelvis here shown in pink, true pelvis shown here in blue. And I'm not going to go over everything in this diagram, but you guys should know that there is one question on the exam where you're asked to identify whether or not a particular pelvis that you guys find in the, I don't know, is it CSI or whatnot, is going to be male or female. And I'm not sure exactly which the parameters that I gave you, so you'll have to know the difference between the pubic arches, for example, the pelvic brims, the ratio of the false to the, not the ratio, whether or not, say, this is going to be more shallow, that's going to be more deep, so that the angle of the false pelvis. So make sure that you know the major differences between the male and the female pelvi. All right? All right, moving down to the lower extremity. That's going to start with our femur. It's our thigh bone. Has the head region that articulates with the acetibulum and a greater and a lesser trochanter. As we move down the body and end up to the epicondyles, we've got the lateral condyle and the medial condyle. On top of those, we have the lateral epicondyle and the medial epicondyle. The lateral and medial condyle are going to interact directly with the tibia. Well, not directly, because we're going to have the meniscus and whatnot together at the knee joint, but they're going to articulate there. And then we also have the patella, which is the kneecap, that's going to articulate with these bones as well. On the outside of the leg, the lateral area, we're going to have the fibula, which does not articulate with the knee joint. It's going to articulate with the tibia directly. And then on the bottom is going to articulate with the tarsal bones. The patella is going to have an articular facet that's going to allow for the medial femoral condyle here to be able to rub along it, and then an articular facet for the lateral femoral condyle. So this is the medial, there's the lateral. So it's going to allow for articulation with both of those. And you can see here's the knee, or sorry, the patella sitting right on top of that. Okay, the tibia is going to be the shin bone, the medial leg bone. We have a couple different things, including this tibial tuberosity, which is an attachment site where the, right here, where the patellar ligament is going to attach. Then we have the interosseous membrane between the fibula and the tibia, similar to what we saw between the radius and the ulna. As we move down the tibia, we have the medial malleus, which is going to be that inner part of the ankle bone that you might accidentally kick as you're walking past furniture, but you didn't gauge it properly. And this is the lateral malleus, and that's actually going to, sorry, malleus, that's going to come from the fibula, and it's going to be the outer ankle bone that you might kick accidentally as you're walking around your house. All right, here the medial malleus is going to connect to the talus and to the calcaneus. The calcaneus is the heel bone. Okay, so the navicular is going to be one of those bones here, and let's just go ahead and look down at the tarsal bones. So here's our tarsal bones. We have ankle bones. There's 7 of them. So remember, we saw 8 in the wrist. In this case, we've kind of changed the formation between the wrist and the ankle, because the ankle is meant to be weight bearing. We're going to have weight going straight down. So the calcaneus is going to take that weight. We also are going to have the navicular bone here, and then the cuneiforms, 1, 2, and 3, your first, second, and third cuneiforms. So our tarsal bones are going to include the talus and the navicular, the calcaneus, the first, second, and third cuneiform. After that, we're going to have our metatarsals, again labeled 1 through 5, starting with the big toe, 5 being the pinky. And then the same thing with the phalanges. All of them have 3 except for the big toe, which only has 2. So the ones that have 3 have proximal, middle, and distal. The big toes are only going to have middle and distal. The great toe is known as a hallux. And remember in class I said that's a great Scrabble word. Okay, so you'll have to know the different connection points for these different bones. So which bones do they articulate with? Both on the proximal end and on the distal end. All right, we also talked about the arches. So we have different arches in the feet. Here we have a longitudinal arch, which are the medial longitudinal and the lateral, medial longitudinal and the lateral longitudinal arch. And then here we have the transverse arch. And that's going to basically be the curvature that's going to allow your feet to have a little bit of a spring in your step, for example. All right, so that's going to wrap up Unit 8. Let's move on to Unit 9. Unit 9 is referring to joints and articulations. So we have 3 major classifications of joints. We have fibrous joints, cartilaginous joints, and synovial joints. Okay, fibrous joints are going to be anytime we don't have a synovial cavity, and the articulating bones are held together by connective tissue, an example being the tibular fibular ligament, or a syndesmosis, which is an example of this is a gomphosis. This is in it when we have the tooth and the socket of the alveolar process interacting in a joint fashion. These are not supposed to have motion, right? They're supposed to be little to no motion permitted. Other examples include coronal suture, or just sutures in general. Like a coronal suture is a specific one they're showing you here. And the sutural ligaments are going to basically be holding 2 different bones together. And while we can have slight motion, we're not going to permit a very large range of motion. Fibrous joints are going to include sutures, syndesmosomes, interosseous membranes, etc. And we talked about each of those and what they are. Cartilaginous joints are going to have no synovial cavity, but articulating bones are going to be connected by cartilage. An example here is the cartilage that's found in the epiphyseal growth plate that's going to connect the epiphysis and the diaphysis. So that's going to be considered a cartilaginous joint. That's called a synchodrosis. Another example is a symphysis, like the pubic symphysis, which is going to be similar to the intervertebral discs, where we're going to allow for the articulation between 2 of the pubic bones or the hip bones. The third type is going to be the synovial joint. Synovial joints are going to be a synovial cavity. They're going to have fluid inside of them. So the articulating bones are going to be freely movable and going to have some fluid inside that allows for motion without the bones grinding. So we're going to have the articular capsule. On the outside have the fibrous membrane, then inside the synovial membrane. After we have the synovial membrane, then we have the synovial fluid inside the joint cavity or the synovial cavity. Remember, that's all going to be lined with synoviocytes, which are specialty cells that are going to help release that fluid back into this cavity. We also are going to have articulating cartilage. It's going to cover both of our articulating bones, keeping them from interacting with the grinding method. Instead, they're going to slide easily along one another because they're cartilage that's going to be interspersed in a nice synovial fluid. All right, we talked about all the different ranges of motions that we could have at the synovial joints, including gliding motion, which I didn't show you, but this is when you're moving your wrist back and forth is a good example of this. Also, we talked about extension, flexion, hyperextension, how a hyperextension might be bad in certain joints like the knee and the elbow, or will be bad in those joints, but could happen with no problem and is a normal range of motion in other joints like your cervical intervertebral joints or your neck. And so we can have flexion, extension, and hyperextension at a lot of different joints. And so that's basically just saying whether or not we're contracting our muscles or extending our muscles. We also have abduction and adduction, and we talked about how adduction we're going to be taking a single unit of single units and making it 1 unit of 5, so we're adding it together, right? So abduction is going out and adduction is coming in. We also talked about circumduction, which is kind of specialty to your ball and socket joints. So you can have flexion, abduction, extension, and adduction all in a series of sequences to allow for a nice wide range of motion. Again, we can do this at our shoulder joint and in our hip joint, and also at some saddle joints, like our thumb, for example. So condyloid joint and saddle joints and ball and socket joints are able to do that. So an example of condyloid joint would be like the jaw. Right, we can do circumduction at the jaw as well. We also have rotation, where we're able to move, for example, left and right. It would be if you're looking at the arm, we have lateral or medial. If you're looking at the head, it's just going to be left or right rotation. Lateral rotation is when we're rotating either outwards. Medial rotation, we're rotating inwards. Specialty motions that can happen only at, for example, the temporal mandibular joint include elevation and depression. Oh my God, right? Or I'll just keep my mouth shut over here. Protraction is when we stick our jaw forward. Retraction, we bring it back. Our intertarsal joints or our ankle bones allow us to do inversion and eversion. So picture your toes coming up towards the ceiling, eversion, your pinky toes going up towards the ceiling. And also we're allowed to do or capable of doing dorsiflexion and plantar flexion in our ankle joints. With our wrist joint, thanks to that interosseous membrane, which is actually considered a joint as well between the radius and the ulna, we're able to do what's called supination and protonation. So supination is putting your hand out for a quarter, protonation is putting your hand out for a hand stamp. Carpometacarpal joint allows us to do the process of opposition. This is opposable thumb, separates us from apes, for example. And you can only oppose your thumb to your other fingers. You can't, for example, oppose your pinky and your forefinger, although you can make them touch. Opposition means that the nails are going to be on opposite sides, and the actual surface of the finger, the palmar surface of the digits, is going to be touching. All right, again, that's all labeled there. I would use this as a summary, so I would come back to this at the end and make sure that I know it. In fact, when I was going through this, I would probably be making all of these motions. And as long as you're able to get it right, you should be just fine for the exam. Again, this might be another region where I would put on a bunch of Post-its and then just go over it until I figured it out. But again, this is probably somewhere where personally I would be making these motions. I'm actually physically making my wrist gliding, for example, when I'm looking at this. And that will help you remember it in the exam as well. All right, we are also going to classify our synovial joints by the different range of motion that they provide. So they can be uniaxial, biaxial, triaxial. So here's an example of a planar joint. Planar joints are going to allow gliding motion, back and forth, side to side motion. Usually that's going to allow for biaxial, triaxial motion as these bones are rubbing against each other. We can also have a hinge joint. A hinge joint is a lot more rigid in the range of motion that it provides. A good example of this is the knee, for example, or the elbow. And basically with this, we're going to have an end point of our range of motion because the hinge joint is actually going to lock in place, right? The ulna, the olecranon of the ulna is going to lock into that olecranon fossa, and we're not going to be able to hyperextend. All right, we also have pivot joints. Here's a good example of a pivot joint. We're able to do uniaxial motion in that one axis of motion is rotation. A good example of that is the radial ulnar joint. The difference between protonation and supination is going to allow us to have that uniaxial rotation. All right, condyloid joints are ellipse that are kind of like ellipse shaped, allow us to do biaxial motion, and they're going to have it when we have one oval shape fitting into an oval bowl, so an oval protrusion into an oval depression. And examples are going to be a lot of different flexion, extension, abduction, adduction, etc. Radiocarpal joints are a good example of this. The metacarpal phalangeal joints are going to be a good example of this, except for the saddle joint that is found in the thumb. So the saddle joint is a very special joint that allows us to have the opposable thumbs. It looks like this, and it gives us biaxial range of motion, but because we can go any combination of forward and backwards and left and right at the same time, it's going to, or you can say up, down, left and right, all at the same time, we can basically get something that's similar to, but not quite as close to circumduction that we would see in the hip. So it is classified as circumduction in that we are able to get a full rotation, but it's not going to be the same thing that we can do with our arms, for example. We can make a full Ferris wheel structure with our arms. We are not able to do that with our thumb. We're more able to make like the outline of, say, a vase or something like that, or a glass. Ball and socket joints, classic examples. Obviously, our hip and our shoulder, right, where we're going to have the head interacting with the socket. So here's the acetibulum of the hip bone where the head of the femur interacts. That's going to allow for triaxial motion, which allows us for circumduction, flexion, extension. It allows for almost all of the options in terms of motion. Now, let's see. Which joints do I want you to know? The temporomandibular joint is going to be the connection between the temporal bone and the mandible. So this is your jaw. This allows you to chew. So yes, you will need to know where the styloid process connects on the mandible, for example, and with what ligament. So the stylomandibular ligament does that. I have a couple different angles here for you for the jaw joints. So this is going to be a medial view. Here we have the sphenoid sinus. So we've kind of cut in half of the bone and we're looking outward from the inside of the mouth. This is the mandible, and here we have the connection of the stylomandibular ligament. Here we have another stylomandibular ligament, and here we have our articular capsule. So this is just showing you a couple different views. I think we get one more. This view is going to show you where we have the actual interaction of the mandible with the mandibular fossa and the temporal bone, and how that's going to then have a layer where we have a superior and an inferior compartment, but that layer is going to be touching the bone, right? That layer is going to have synoviocytes, so it's going to be a nice synovial membrane. Inside that, we're going to have synovial fluid in this articulating region. Okay, so a nice synovial cavity that's going to be fluid buffered, right? The next one I'm going to talk about is the shoulder joint. Now, if I talk about every detail of the shoulder joint, we will be here all day. So know that you just need to review the shoulder joint such that you know all of the different bones that are involved. There's only three: the scapula, the clavicle, and the humerus. The different regions of the scapula and what they are. Here's the coracoid process. That's the acromion. The different regions of the clavicle and how they connect. Which ligaments connect them where? The acromioclavicular ligament, for example, connects the acromion to the clavicle. This one is this is the trapezoid ligament, but here's the coronoid ligament. It's going to connect the clavicle over to the coracoid process. Here's the acromial ligament, connects the coracoid process to the acromion. We also are going to have a ligament that wraps around this. This is the transverse humeral ligament, and the glenohumeral ligament is going to be found inside the cavity of the actual shoulder socket. We also have some bursa, subacromial bursa, or this is the subscapular bursa, and this here is going to be the bursa that's going to line the tendon of the biceps brachiae. All right, so if we have a lateral view of the shoulder, we're basically taking the arm off of the skeleton and we're looking inward into the, well, it looks like a coconut, right? This is going to be the glenoid cavity. The glenoid cavity is going to be comprised of, so we've got articular cartilage is going to be inside here. Then this is going to be called lots of glenohumeral ligaments around it, and the bottom of that is going to be the glenoid labrum. All right, this gives us a pretty good view of some other things like the coracoacromial ligament, which is going to connect the acromion of the scapula to the coracoid process of the scapula. So this ligament is going to connect one piece of the bone to the same bone, but in a different region. Then we have the subacromial bursa underneath that, and the tendon of the supraspinatus muscle. We also are going to have here the tendon of the subscapularis. Here's the tendon of the infraspinatus. We have some muscles as well that are going to be shown here. Here's the teres minor. The teres major is going to be right in that same region. So again, when we're looking at this, we're not just thinking of the bones, we're thinking of the ligaments, we're thinking of the bursa, we're thinking of the tendons, we're thinking of the muscles, right? So think very clearly about how these bones articulate with one another by connecting at which regions and using what, ligaments. Okay, so again, all kind of the same stuff, except now we're looking at a frontal plane. Here we have the acromion of the scapula, the clavicle. Here's the connection of the acromioclavicular ligament underneath that subacromial bursa. Here's the tendon of the supraspinatus muscle. Here's the supraspinatus muscle. This is the glenoid cavity right in here. The glenoid cavity is going to be filled with synovial fluid. Here's the synovial membrane. Outside that we have the fibrous membrane. We're also going to have the synoviocytes that line it, that create that synovial fluid. Here we have the articular cartilage. It's shown in light blue. It's going to line both sides of the bone to prevent rubbing and wear and tear due to friction. And then we also have this articular capsule, which is going to wrap around the tendon sheath of the biceps. So it's going to protect it from direct wear on the humerus. Okay, so let's move on here. This is going to be the elbow joints. The elbow joint is going to be comprised of the humerus, the radius, and the ulna. Remember, if you can't figure out which is which, just go ahead and touch that elbow. That elbow is going to be what you're thinking of when you think of the elbow is going to be the olecranon of the ulna. which connects with the humerus. So the olecranon, you follow that down. That's going to take you down to your pinky. That's how you know the ulna is going to connect to the pinky. Radius is going to connect with the thumb. All right, here's the olecranon bursa. We have several ligaments here, including the ulnar collateral ligaments. Here we have articulating cartilage, articular cartilage. On the end of the humerus, we have the medial epicondyle. We also are going to have the lateral epicondyle. Remember, those are going to interact specifically with the radius and the ulna. But you can't see that because we have all the ligaments not in the way, but depicted here. We also are going to have a ligament that wraps from the ulna all the way around the radius. It's called the annular ligament of the radius, and it's going to help hold that ulna directly in place to the radius, and assisted by, of course, that interosseous membrane. All right, let's see. We have some collateral ligaments, the radial collateral ligament here as well. We were looking at the ulnar collateral ligament previously, so it all depends on the angle. If you're looking at the medial aspect, you're going to see the ulnar ones, which makes sense because that's going to be closest to the ulna. If you're looking at the lateral aspect, you're going to see the radial ligaments because those are going to be the ones that are closest to the lateral side. Okay, let's move on to the hip joints. Here's the hip joints. We're going to have the hip bone. Again, it's created from the ischia, the ilium, and the pubis. And then we have the acetibulum, which we can't see here because we have all the ligaments, but the acetibulum is going to connect the head of the femur into, so that's the ball, into the socket. The acetibulum is the socket, basically. We have several pubofemoral ligaments. We have iliofemoral ligaments. And then some bone surface markings of interest, like the greater trochanter of the femur, the lesser trochanter of the femur, and the femur itself, which on this side is going to connect at the knee joint. This is the obturator canal we saw previously, which is now going to be depicted with the membrane lining most of it. We do have a little bit of space in that obturator canal region. So sorry, this is the obturator foramen. This is the obturator membrane. That's the obturator canal. And what's going to run through that canal is going to be things like nervous tissue, vasculature, muscle, etc. Okay. So again, here's the hip bone, and the acetibulum is going to be the region where the head of the femur articulates. So that's the head is going to be the ball with the socket. The acetibulum is the actual socket. All right. So here's another view of the hip. We have several ligaments. Again, the iliofemoral ligament depicted here. Ischiofemoral ligament, that just means the different regions of the hip are connected to the femur, right? The ilium, remember we had the ilium, the ischium, and the pubis. And again, the different trochanters, we have the greater trochanter and the lesser trochanter of the femur. If we take our frontal plane, we can look at the actual articulation. So here's the hip bone. There's the synovial cavity. Remember, the synovial cavity is going to have synovial cartilage on one side. So that's blue, the articular cartilage. Then in yellow is the synovial fluid. On the outside, we have the synovial membrane in red. That's going to help keep the fluid inside so we don't lose it, obviously. And then around that, we're going to have a fibrous sheath or a fibrous membrane. Okay, we also are going to have a ton of the different ligaments. Here's the articular capsule that's going to wrap around. Here's the transverse ligament of the acetibulum, for example. And then this is the zona orbicularis, which is going to wrap around basically the very head of the femur to help hold everything in place. All right, again, greater trochanter and lesser trochanter of the femur. All right, now I'm going to move down to the knee. So the knee is going to be interacting directly with the femur. So here's the lateral condyle of the femur and the medial condyle of the femur. I apologize, I must be speaking too quickly. The lateral condyle of the femur is going to interact with the tibia through the lateral meniscus, and the medial condyle is going to interact with the tibia through the medial meniscus. Inside here we have tendons, we have the ACL and the PCL. These ligaments are going to be running through and kind of allowing for a little bit of rotation, but keeping things in place so we don't end up with too much pivoting. So again, here's the PCL, there's the ACL, these are the meniscus, here's the lateral meniscus, the medial meniscus. You can see how the lateral medial epicondyles would just fit right on in there, protecting the tibia from direct contact with the femur. Also of interest here's the fibula. The fibula is connected to the femur by the fibular collateral ligament. The tibia is connected by the tibial lateral ligament. Tibular collateral ligament. This is kind of showing some of the same things, but now we're taking a sagittal plane, so we're going right on through. Here we have the femur, this is the patella, this is the tibia. This is the articulating cartilage, shown in blue. We have the synovial fluid in the yellow region here. Here we're going to have the lateral meniscus. That's going to be depicted here, and the the medial meniscus will be depicted there. We have several bursa that are also shown here. Bursa are going to be found in the prepatellar region, and the infrapatellar region, and the suprapatellar region. What do I mean? Above it, in front of it, and just beneath it. This is how we kneel, right on those bursa. This patella is going to kind of slide up. These bones are going to press down on those bursa, and so that's how we can kneel fairly relatively comfortably. We're not kneeling on our patella. The patella is actually pushed upward a little bit. All right. So again, this is just going to be a lot of orienting yourself to how these muscles articulate with each other, where the bones are going to articulate with each other. What's involved in the joint is going to be the muscles, the bones, the ligaments, the tendons, etc. All right, so that's going to wrap up the knee. Let's talk about some of the tendons. I guess the tendons are going to come down from the quadriceps, go across the patella, and then we're going to have a ligament on the bottom called the patellar ligament that's going to connect to the tibia. Again, in the back, we're going to have different types of ligaments, the ACL and the ACL and the PCL. There's also the tibio-collateral ligament, the fibular collateral ligament. Here we have the medial meniscus, the lateral meniscus, the tibia itself, and the fibula. All right, guys, that is going to take us to the end of our review, and I managed to do it in a relatively reasonable amount of time. So if you guys have any questions now or during the exam, go ahead and shoot me either an email, or if it's during the exam, it's probably more pertinent for you to shoot me a text message, and we can go ahead and get those answered for you. All right. Thank you so much, and happy studying. Aloha, and have a great day.